our lovely presenters today. We have Amrish Joshi joining us. He is a physician with the Integrated Hospice-Palliative Care Program in the Richmond Community Care within VCH. His clinical work has focused on palliative care, but previously he was a full-service family physician in South Surrey for over 7 years. He has an interest in the cultural approaches to providing the best clinical care, particularly within Asian and South Asian communities. He enjoys trying to complete triathlons and his ongoing dedication to Wing Chun Kung Fu. Thank you, Amrish, for being here. And then we have Lara, who's the clinical nurse educator for the Integrated Hospice-Palliative Care team in Richmond with Amrish. Lara feels strongly about supporting direct care clinicians to enhance patient and family outcomes. She also enjoys lending her passion and knowledge to enhancing and developing education to support excellence in clinical palliative care. Thank you so much, Lara and Joshi, Amrish, for your willingness to share your learnings and experiences. And I will pass it over to you. I'll stop sharing my screen and then you can go ahead.
Thank you so much for the introduction. A really pleasure to be here this afternoon. So we're just going to start off by just giving you a bit of background, what we have been doing as a team here in Richmond. So really, you can see the story behind the Gift of Pearl campaign. This will be something that hopefully we'll get time at the end to talk about how we did our knowledge translation with a study we did, which was really looking at advanced care planning, advanced care directives with members of the South Asian culture and using the Serious Illness Conversation Guide. So basically, let's go to the next slide. Okay, just want to acknowledge the funding that we received from the VCHRI and Richmond Hospital Foundation. Without that help, we wouldn't have been able to do this research and we wouldn't be talking to you this afternoon. So what are we going to try and do? We're going to talk about what we did with this study, the advanced care planning with the South Asian community, talk a bit about the background, what were the objectives for that study, how did we approach it, what was the methodology, and as I said, hopefully we'll have time to share knowledge translation. And I have got an exciting exercise that we're going to do. I'm going to share Prezi for those of you who have not seen Prezi, really getting you to interact and share your experiences, because you all do this work and you've all had experiences with different cultural groups, and there's valuable pearls that we could all learn from each other.
Okay, so before we kind of dive into the breakout rooms where we'll be kind of tackling some case studies, Amrish and I thought it would be nice to just provide some background information for what informed our research. So as we all know, the South Asian community really makes up a big portion of our population here in BC, and we thought that it would be a really great opportunity to build up on a previous study that we did here in Richmond with the Chinese population. So really focusing on some of their, experiences when navigating, healthcare as well as palliative care services. In terms of the objectives, we really wanted to explore the understanding and beliefs around advanced care planning, specifically using the Serious Illness Conversation Guide, which a lot of us have been using in our clinical practice, and applying that into a situation where we had Amrish pretending to be a South Asian gentleman navigating palliative care services. We are kind of acknowledging that it was specifically a palliative care example that we used in our research study, but it could really be applied to anyone who's experiencing a serious illness. And for anyone who's interested, there were just a couple of focus groups that we engaged with. Quantitative data really looked at collecting demographics, but the bulk of our analysis was from the themes and sub-themes that we kind of took away from the focus groups. And that's what we're hoping to share with the whole group later today after the breakout rooms. And eventually, we also hope that after you attend today's session, that you'll be able to take a couple pearls of wisdom to take back into your practice to be able to provide more culturally sensitive and appropriate care, not just to people from a South Asian background, but hopefully for other, patients and families who might be coming from a different culture.
And I just want to add, we're not providing a cookbook here that you see a particular individual who you may assume is from a certain cultural group. We know there are cultures within cultures, it's really providing you that knowledge, that awareness of how you navigate challenges when you're having these really difficult conversations. So that's the idea. And again, we're sharing it from our community here. And yes, we're trying to generalize it. But again, it's raising that cultural awareness, which is why we're all here this afternoon.
Mm-hmm. And I believe that Laura and Esther will be casting some of the case studies into your breakout rooms in a couple minutes. What we're really hoping to do with the case studies is, pull from your own experiences of working with, families from a South Asian or even from other cultural backgrounds in terms of what worked well, what didn't work so well in those conversations, whether it was advanced care planning, applied to discharge planning, and what are some of the concerns that you might have given some of the information that's provided in the case studies provided.
Yeah, I was just going to really just ask that please, designate someone to take some notes. Really want you to share 2 or 3 or more pearls that you may have, challenges that you've had, and then really we'll do this exercise, which I hope you'll all enjoy, which is really going to be the bulk of this presentation this afternoon.
And I believe we have about 5 minutes. Is that correct, Laura and Esther? Yes.
Yeah.
Okay, so I'm going to put everyone into their breakout rooms. Quite a few of you didn't get a case, but I understand a lot of you are still having a rich discussion, so apologize for that. So I'm just going to get into the media part of this presentation. Before I go into it again, I just want to acknowledge that this work was done with the help of other team members, Enrique Fernandez, Sukena Kara, and Alina Wang, who helped us with this project. So just really want to acknowledge the hard work that they put into this project and what we're going to share with you today. I don't know why I chose honeycombs, but I think it must have been summer and maybe the bees were around me, so I decided to go with this theme. So I'm going to overwhelm you with hexagons. So here we have really these cultural themes or themes that came out from our study. It's changed quite a bit, and but really the actual essence of it is much the same. So what I'm going to do is I'm going to put group 1 in the spotlight, and I don't know if you have nominated one person, and maybe that individual can speak and just say, maybe share one challenge they would see, or maybe a pearl in relation to the case that they had or didn't have when it comes to having this conversation with someone who may be from a South Asian cultural background. So can I get someone from group 1 if they don't mind? Do we have anyone?
I think we were group 1.
Okay.
And we couldn't see the screen sharing until just now. So thank you for putting that up. And for our study, a woman with what sounds like end-stage cancer. And we talked about a bunch of the different factors. And I think one of them was about who's making the decisions and who's the best person to support the individual and the family, whether it's, thinking of myself coming in, I'm from a spiritual health practitioner, is that, balancing individual autonomy, the family decision-making, logistics of who's going to be communication. Do you want to, is for me as, as a man, as a white man, or am I the person for you to talk to? One of our other people saying, well, I'm assuming as an Asian woman, she'd want to open up to me, but maybe then but maybe it's actually her children that she trusts the most and wants to talk to. So we were saying, trying to get the sense of what voices are at the table and who's the best team member to be connected and supporting.
So Wade, thanks for sharing that. And you've actually touched on a couple of those themes we've got there. And I'm going to give you a choice to pick one of them. So you talked a little bit about different healthcare systems. Yeah, this is the exciting bit. It's like, it's not a game show that you're going to win anything, unfortunately, but choose one of those hexagons that you think may apply to some of the things you were talking about. So you touch a bit about autonomy versus paternalism, power, family dynamics, different healthcare systems. Which one do you think that you want to take a stab at and see if you sort of win that car or whatever it is,
I think we touched a bunch of different things, but I think probably autonomy versus paternalism is what we were talking about the most.
There we go. So in our group, across all groups, they mentioned family was identified as a major factor influencing how these discussions take place. So they're saying, look, if you're going to have these conversations, you need to involve family. And again, you might say, well, that's with all cultures, but specifically in this group said you're going to have to include that. Do you want to take one more shot because you got one point for that? Do you want to choose another one in that?
I'm going to see if anyone else from my team wants to jump in.
Oh, does anyone else want to jump in from group one?
Yeah, I agree that autonomous paternalism we were talking about, because it was a situation with a woman who was deferring to family in a difficult situation. And I guess the other question, though, she's different culture, different language. So I'm not sure if acculturation fits that, or what else. I'm trying to close my, there we go. I mean, in our scenario, it was deferred to the family, but it also described quite a extended family, brothers, sisters, as well as her own children and things too. So power dynamics, we don't have any clue in our scenario that there's any power dynamics, but certainly we acknowledge the likelihood that she would really want the family to be involved, and then try and identify a spokesperson, as well as arrange an appropriate venue to have a discussion with the relevant family members to try and begin that.
Perfect. So John, what I'll do, I'll choose this one for your power dynamics within the family. Okay. Sure. So, there's a hierarchical structure within South Asian families which can sort of influence how you have these conversations. Who's going to be the medical decision maker? Again, there's a hierarchy. The younger members may not have such a voice, and they have to defer to the oldest, even though they may want to say something. So they feel they have less influence. And the decisions tend to fall on the oldest or the eldest child. So just a comment here, even to raise these type of issues is challenging, because that's not something that someone younger or sort of lower in the hierarchy of the family should be questioning or bringing to light. The elder or the elder family members are typically in charge of decision making. Yeah, perfect. Thank you. All right, group two. Does someone want to take a stab at this and just share what they found, and if there's one of these themes that they want to pick? Anyone?
I think we were group two, and we also didn't have a scenario at first, so just started talking in generally, but really talked about the serious illness guide or discussion guide being a guide, and being able to be adaptable with how we utilize that. So we talked a little bit about how some families are uncomfortable sharing diagnosis, prognosis, and then how, I guess, when the scenario came up, how to approach SDM and discussions. So really looking, I guess, at the patient and family as a unique entity. So I guess as far as picking from your things, maybe it would be falling under death as a taboo.
Yeah. So again, no surprise. Again, not specific to South Asian culture, but there is an avoidance of discussing death and dying, declining health, which can also be a challenge then when you're having these serious illness conversations. What time do these conversations happen? And so again, I've got a couple here. Do you want to choose one of these, Nikki? And then I'll jump in and give others. Which one is facade, maintaining hope, general taboo, damaging relationships?
I think maintaining hope. Yeah.
So basically there's this avoidance, particularly among the elders, because it's perceived as being harmful to have these conversations. They don't want those members of the family to lose hope. And actually this is not, it's sort of consistent with quite a lot of Eastern sort of cultures that, we don't want to have this conversation and upset our loved one. We don't want to share it. So again, just to read what one individual said, that desire to kind of hold on to hope would kind of shut down any conversations. If you become sicker, what would you do? I think that would be very triggering. So it can be really quite a challenge to open that conversation, to be aware of it. Yeah, thank you. Okay, third group. Today I want to jump in and maybe sort of share what they discussed.
Okay, so we were in group three. We didn't have a case study, but it didn't stop us from having really fulsome conversations, looking at the hexagons that are left. I think different healthcare systems, we talked about the fact that we are providing care within a Eurocentric, Western, predominantly white healthcare system, and how do we help to make our patients and families feel safe enough in order to have the kind of conversations that we need to have, and safe enough to discuss the topics that they're really struggling to have, and that, particularly if they've come from another country and the way in which healthcare is provided is very different to the way in which we provide it here. So I think that different healthcare systems one applies.
Thank you, Liesl. So here we have, there was this, they acknowledged the lack of awareness and presence of, in this case, palliative care services and ACP conversations in their countries of origin. It doesn't happen. It's not a concept. And then the decision-making process varies. Okay, you're asking the patient, you're asking my mom and dad. Well, actually, we're not used to that. That sharing. Usually, you just tell us what to do. You lead us. So really, that was really quite a challenge. And again, do you want to pick one more along here, Liesl, as you've just chosen the different healthcare systems?
I think clinician-patient relationship. We were talking about, one member of our group was talking about the fact that there are, where they're working, there's very few, maybe there's like predominantly white care providers, and how that makes it that much more difficult to create a rapport and a bond of trust. Whereas if you have patient and care provider from the same culture, it's easier to build trust and rapport, that sort of idea.
So, this didn't come up specifically in ours in terms of the setting or the way you sort of presented it, but what did come up again was what you touched on earlier, is autonomy is a central tenet in the West. But in South Asian countries, there's more of this collective decision-making, the expectation that the clinician will direct care. They're the authority. So it didn't really necessarily come up in terms of, say, which particular race that clinician was from, but definitely you're going to tell us. So in my country, there's not such a concept of advanced care planning. Most of the decisions are taken and made by the family members. And again, the clinician would lead it rather than asking us. Okay. All right, so we're on to group 4. So someone from group 4 want to jump in.
So I, from group 4, started talking about was, how do we begin the conversation? I think that's where we got. So each one of us shared from that point of view. And I would say, if I were to pick one of the hexagons, I'd say, it's like the building the relationship, clinician and patient, just trying to find out, one clinician said, using the patient's own words to find out where they are. And then, the other one was that we're asking them, the patient or the family members, what they know already. And then others were talking about, what they're worried about, what brings them joy, that kind of thing. And we had one clinician who works in the kidney clinic where people have opted not to have, dialysis, I believe. And so in that scenario, again, it seems different because, it seems like, they have a plan to guide patients and to explore with them where they're going. And so that's, that's what we got to in that time that we
You're going to choose
have.
one of them. Which one do you want to look at and maybe try and explain what you think is coming up? And again, this is in our group. I'm not saying any of the suggestions made so far are not valid, because I mean, we only could cover what came up in our
Yeah, sure. So I'm thinking, for us, it felt like it was an empowering the patient, and when we are culturally unfamiliar, whether it be where they're from or how they view our healthcare system, I would say.
So again, it comes with these different healthcare systems, as you mentioned. They may not understand the sort of patient-centered structure to sort of the healthcare system in the West. And asking for consent and letting the patient direct their care may be actually a foreign concept. So one of the things that also came up, sometimes you need to be aware when you ask and say, do you have any questions? They may not have any questions, not because they don't want to offend you by asking it, because it's something that they're not used to. So again, I'm going to read this out. I think it's really powerful, which is why I like reading them out, because the doctor is asking permission, which deviates a little bit from that the person is the expert, like the doctor is in control. If the doctor doesn't even know they're in control, how can they control my health? So there's another aspect to this as well. Like, this idea of what do you want? And it can be taken as, well, what do you mean? You should be telling me what I should be doing. So again, how that plays into that conversation. And again, it's not a cookbook. This is just some of the things that you may come across. You may think, why am I sort of meeting this barrier, and how do you navigate it? So Lenny, I think you were group 4, and I think group 5. Anyone from group 5 want to jump in? Please say you had the case.
Sorry, I don't know if you can see me.
Yes, I can. Hi, Sal.
Hi. So I think we kind of talked a lot about what's already been said, but what I can maybe add to that too is in our group, we did talk about it depends on really what is the context of this particular family. Yes, we have a lot of generalizations about some South Asian cultural values and whatnot, but what are the dynamics and decision making situations and awareness in this particular family? So it could be part of acculturation, it could be autonomy and part of paternalism. And I just wanted to speak maybe briefly to the role of faith hexagon, because as we often, in my experience, and I'm sure this is true for our clinicians as well, is that in a lot of our Eastern philosophies, there is that, it's up to God, it's up to God's will, whatever happens, right? So, so I think in our conversations, it's also very important to acknowledge that piece. Yes, that it is up to God, to whatever happens will happen. And at the same time, what can we do together with God, with God's help in terms of helping you, So I think the power of faith and religious customs and kind of integrating that into our conversations is very important.
Thank you, Sabi. Literally, you read off from those hexagons without me even revealing them to you. So I'm just going to go on to it. I mean, this was the breakup. I know it's not representative of really the bigger community, but coming back to religious customs, there would be, it does have an impact on how these conversations occur. In our group, we didn't have a specific religion that flagged, but that's because these beliefs are enmeshed in the whole culture, right? So it's shared sort of across those different religious groups. But it also has a major impact, particularly on the older generations, that is very important to them in terms of death and dying, and really how that should be incorporated when you have those conversations. And you touched on this theme, Saab, fatalistic belief that things are predetermined. What will be. What's the point of trying to change it? What will happen? Either God will take care of everything, or just decide whatever is going to happen. There is no planning that will supersede that provided by the Almighty. So again, that fatalistic approach. And then, power of faith. The younger participants acknowledged there's a role, but it wasn't as impactful in terms of their decision-making compared to the elders. And so again, I think culture plays a much more important role than religion, if someone had said, but religion does play a role in our lives. So again, something to be aware of. So thank you very much, Saab, for sharing that. Now we're on to group 6. Anyone from group 6? So back to group 1 again. Does anyone from group 6 want to jump in?
I can speak, it's Aileen. We discussed some of the challenges from just not being familiar with other people's culture and how they approach death and how they approach talking about it. And again, within the family and the family dynamics, and how to and when to have these conversations, and a series of conversations were some of the things that we addressed. Maybe anybody else in the group, did I forget something?
So what I'll do, Eileen, I'll touch on those. So you talked a bit about, again, a bit of like those conversations, that facade. We call it the language of love, because most of the time it didn't come from a malicious sort of approach. It was about protecting each other. So you hear this case, hey dad, you're going to be fine, you're going to live another 100 years, and the father saying, yes, don't worry son, I'm going to be fine, even though the reality is they both know something's happening, but that's that facade that's playing out, maintaining hope, a way of showing love. It's a deliberate maintaining this false reality despite declining health. The patient does it, the family member does it. It's a coping mechanism, okay? So again, I can remember cases where my father has come home and said to the doctor, the doctor said everything's fine, and I can do all those things. But when he followed up with the doctor, it was very different. So, that might be one reason you come across and say, well, do this family get it? Do this patient get it? They do. It's just that's how they're able to communicate and deal with that. And then the coming back a little bit to this damaging relationship, again, we're having this conversation. If individuals said, look, this conversation could be viewed as being disrespectful to our elders. I'm having this conversation in front of my elders. That's really not something that I think would really help. And we feel it may damage our connection and our relationship. And definitely the younger members felt that was the case if they were to bring it up with the elders within the family. And then I'm just going to talk a bit about the acculturation, which I think a number of you have touched on. What we found in our group, the longer they had lived in Canada, they were more comfortable having this conversation and more likely to be happy to be involved in it. And definitely the younger generation, because they're more aware of that approach, we're very comfortable having the conversation. So again, something just to be aware of, how do you approach it and what information you might need to gather depending on really how that conversation goes when you initiate it. Now I'm just looking at time. I don't know if there's quite a few left here, and I have left, I'll focus on this QR code so that you can look at the code book that we had. I'm just going to jump onto filial piety. Again, fundamental to family centered approach, sheltering the elders from upsetting news. And then I think a couple of you already spoken about this. They mentioned the family is very large. It can be very confusing. Who is the decision maker? Particularly the youngsters would say, look, I have no say. And the larger the family, the more complex those dynamics. So we don't have to think about what will happen to us. Our kids will think about what they will do. So a lot of the elders will say, look, you don't need to ask me. I'm going to leave it up to the kids to sort it out. I'll make decisions for them based on what I think they would want, but not likely explicitly knowing what it is. So again, this is the idea of maybe not sharing everything with their elders because they're being given permission to take decisions or make decisions for them. Before I sign off and share the QR code, is there any other comments anyone wants to make or jump in before I move ahead?
One of the comments from group 6 Aileen had made was about how much information does the person want? That's an important question that sometimes we don't highlight as much. And something else that I was bringing up was in long-term care was, about the wanting to transfer the person to hospital, those kind of themes. So sometimes it requires many conversations, like more than one conversation over time, and they might shift in that thing. But I was saying the importance of having what can you offer them instead? Because otherwise they think they're going to kill the person if they keep them in long-term care. So what can you do in long-term care for them? So, and starting these communications early in the community, not waiting till they're in long-term care, so repeated early conversation, asking them how much they want to know, and also raise the issue about interpreters and things like that. So yeah. I think you touched on a lot of it already.
Bob, I'll come to you in a minute, but you're absolutely right. Again, there was a lot of information that we found about timing that, again, you look at taboo, this idea of having it early may be a challenge because that's not something that that members will want to do. Leave it till later. What will be. Maybe Sal, I'll let you jump in, please.
Well, thank you. I was just going to add to that in terms of my experience as well, is that it's not, yes, there is that kind of general piece about the hierarchy and elder people making decisions versus younger people, but it really depends on the family too, because sometimes family defer to, somebody who's more educated, somebody who's working in healthcare, somebody who's more articulate, and that can help them understand as well, right? And the other piece, just to kind of keep in mind, I often find, like in our health records, what happens in a family, in a lot of our South Asian families and others as well, is that sometimes a daughter-in-laws are in a role of giving being the caregiver, taking them to appointments, and then, but at the end of the day, sometimes they're not necessarily the decision makers. They're listed as the daughter, but actually they're daughter-in-laws. But when it comes to the decision-making authority, sometimes it's them, sometimes it's not them. So that's always like an issue that I find people often are not aware of. They just call them the daughter, you know?
And so thanks for sharing that again. And again, you know, we only scratch the surface with these themes, and you're touching on so many things that we came up with. As again, this hierarchy, the elder. It could even be down to the fact that it's not the children, it's the brother of the patient, it's the uncle, or it's the aunt. But and again, we didn't have a large enough number to see if there was some sort of gender differences and so on, which I know, having lived the experience and being from that culture, I know there is. But share just some of the small snippets that we had. And again, this is not a cookbook. This is just raising that cultural awareness. So if you are sort of approaching these challenges, you know how to navigate it and know why there are those challenges there. So I just want to reiterate that again. This is the QR code that gives our previous coding. It has changed a bit. Hopefully, you know, at some point we can share that the writer. So that this is the bit that we'll finish in terms of sharing the themes with you, and maybe I'll pass it back on to Lara. We're going to do the gift to Pearl. Do we have time?
I think I'm just conscious of time. If other people have any other comments or questions or anything they'd like to share with the group, because the tail end really was, if we had some time, just sharing some of the quality improvements that we did on the unit, but we also would love to be able to hear from the rest of the group, since I know that there's some very unique experiences as well.
And if you don't, we would love to share what we've done so far. But sorry, Laura, go ahead. Sorry.
Yeah, all good. I just wanted to add that Jessica Blackburn just added in the chat just a comment kind of about the difficulties of engaging in ACP with all these dynamics, and particularly around gaining kind of consent from the patient within all these dynamics. So just wanted to add Jessica's comment in there as well.
It's actually interesting because the hexagons that Amrish has shared are actually part 1 of 2 from the research study that we kind of conducted. The second half focuses more on the different sections of the serious illness conversation guide, and kind of what are the wording that we're using and how some might kind of be more understandable to some of, especially the older generations or people who have just recently arrived to Canada, versus a lot of the younger generations kind of really appreciate and understand the reasoning behind, you know, asking for consent or asking, you know, something as simple as, I think one of the things that really stood out for us, like, what are the critical abilities? That's one of the questions that we ask on the serious illness conversation guide, but that seemed to have landed kind of off for some of the older generations, just because they really focus on very concrete skills, like I was a really great accountant, or something like I raised my kids really well. So we kind of had to look at suggested wording or other alternatives to be able to really capture what it is that that question was trying to ask. So that's actually, unfortunately, we didn't have time to share it, but that's kind of a second half of the study that we were able to pull from the focus groups.
Yeah, I think just following from what Lara said, these questions, they can be seen as very individualistic, you know, and so like when you ask, well, what are your goals? They'll say, well, my goal is for my children to be educated, to be married, to get good jobs, which, I mean, I find that's their goal, but you were expecting they may just be talking about themselves. And it's more about, what does the whole family want? It's not what I want, it's what the family wants. So there was some challenge with the questions, and then the abstract concepts of, you know, abilities, and some words being lost in translation. Again, we haven't shared those bits with you as well. And even the delivery of the seriousness conversation that was saying, look, you know, we're a bit like troubled by some of these negative words. They didn't like fears and worries, for instance. You know, there were negative connotations about it. Maybe other words you could use. Maybe start questions with a positive and say, hey, you seem to be doing okay, we've done this, and then go to the negative. So there were all those things that came up on how you deliver that conversation. And I know each of you, we don't, you know, you don't just do it in one sitting. It could be several sittings. But again, it was really about the words. And again, we used patients who were English speaking, or participants who were English speaking. And again, how to get lost in translation, and how do individuals translate it? And so it is, we've got another study that we're looking to do in terms of how we use interpreters as a conduit and connection with culture, and how words can be lost. You know, is there a word for palliative care? I mean, we didn't have a word for palliative care in the English language until like the 70s and 80s. And so a lot of these cultures, they don't. Like, what is palliative care? What does it mean? What euphemism or dysphemism do they use for that instead? So those things can be challenging as well.
And I guess just a question for Jessica. I know consent, I think Amrish touched on it. Sometimes they kind of didn't need or didn't feel like they had the need to provide an explicit consent, just because they felt like, well, if the physician's speaking with me, of course I'll have this conversation with him. Was there anything specific in terms of getting that consent that you kind of wanted to share with the group?
Yes, thanks. Sorry, I was just thinking more in a big, broad swath about ACP and some of the pieces that we do in community when we are considering things like hospice admissions or the expected notification of death in the home form, and those really form-based decisions that the paperwork that we need to have ready, that this province prioritizes the individual consent from the patient. So yeah, just that piece, yeah, that was what I was thinking about in that particular situation. Thanks.
Yeah, that's really tricky because it touches a lot on a mixture of all the others that were brought up earlier with the hexagon about death being a taboo, or like maybe them deferring to their family for more of a relational autonomy approach to decision making. So I feel like that deserves a whole hour to itself, but definitely can understand the challenges because I'm sure we've all kind of tackled that one from or another.
And it's not, I mean, thankfully there is that section there, even on the provincial DNR, that the patient and family agree with it, but decline to sign it. And so that may be a case where it's okay, I hear what you're saying, but, you know, we just don't feel comfortable signing it. But, you know, yeah, I understand that this is going to happen, and we just don't want to sign the form, but we agree with what you're saying. So I don't know, do you want to, if there are no more questions, did you want to quickly skim through, Lara, or was I going to be too quick for you?
Sure. If there are any more questions, feel free to kind of like share it, and then while I just pull up the slides, because we kind of for some of you who might be from Vancouver Coastal Health, you all might be familiar with the idea of the RPACE program, which is the Regional Palliative Approach to Conversations Early. So I hope you can see the screen okay. I'll just kind of leave it on the PowerPoint slide, but we kind of wanted to share kind of the quick story for the Gift of the Bro, which is kind of the quality improvement, knowledge translation aspect of where the research findings kind of led to. And this was something that we trialed in the Richmond Hospital Palliative Unit, actually. And the idea was you're gifting the pearl, or you're providing the gift to someone to be able to have those advanced care planning conversations, you know, at all or earlier in their journeys. So part of it really was we were just hoping to increase the awareness about advanced care planning, but also something that was easily measurable was the measurement of the documentation of it. So we actually partnered with the Richmond RPACE lead, Monica, and she kind of like was able to distill some of those hexagon themes and how we could incorporate them into the different sections of the serious illness conversation guide. So clinicians, so from physicians, nurses, spiritual health, music therapy, social work, and our allied health team were able to kind of incorporate it into their practice, kind of created a bit of competition about it. So this is just a visualization to kind of keep track of how many pearls have been given throughout the whole journey. So we spanned it from basically October to February. So that's a couple months. And then we're also then in all competition, healthy competition, to have the leaderboard of how many pearls were gifted. So whoever kind of were the top, and if they've gifted 10 or more, then they got a nice fancy shirt that the VCH people kind of supported us with. So that was just something nice for the whole team to engage with. So, you know, very simple, but really trying to make it more accessible for all clinicians to participate in.
I just wanted to add what we did. We actually did a qualitative study sometime back with our Asian community, and we actually combined the two. So actually very similar pearls, and that's what we shared. And again, it wasn't providing a cookbook, it was just a cultural awareness. So if you meet the barrier, why that might be, and that might help facilitate the conversation. So it actually was Asian awareness we shared, and we saw that the uptake of our ACP conversations, the gifting of a pearl, and you can see it's deliberate. You can see a hand, two hands, two pair of hands. You don't know who's giving the pearl, and we sort of took it as we were gifting and receiving a pearl when you have that conversation. So that's where the gift of pearl came from.
And then Monica kind of, our case partner, took all the documentation from all those months and really created a word cloud to really see what exactly was being captured in the documentation. So we're really seeing a big portion of it is family, patients, care. There's obviously some concerns about their pain or the kind of wishes that they wanted. So we just really wanted to end it on kind of a happier note for today's presentation.
Okay.
Great. Thank you so much, Amrish and Lara, for this amazing presentation and for sharing your wisdom and learnings from QI, research, projects, and just experiences alike. So thank you so much. I'm sorry to participants in advance for the technical difficulties we experienced with the breakout room, but sounds like everyone had lots to talk about. It's such a kind of big theme to dig into. So thanks for your rich discussion despite our technical difficulties. So a survey for the session will pop up once you leave the breakout session or the Zoom meeting, and we ask that you all take the time to fill it out. If possible, this is really helpful, important information and feedback for us so we can build better, more engaging future echoes for participants. And then, like I mentioned, within a week, we'll email a session summary and link to today's recording if there's anyone who wasn't able to attend, or if there's someone you think would benefit from listening to this recording and learning this information. There are Learning Hub courses available on culturally safe advanced care planning on Learning Hub. So that's kind of another resource related to this theme that you're welcome to explore and check out kind of for further knowledge enhancement. And then just wanted to add that our next echo in this kind of same subgroup of echoes titled Essential Conversations for the Healthcare Team will be March 5th. It'll be presented by myself, and it'll be about implementation and the barriers and facilitators to implementing serious illness conversations in a healthcare setting. So there'll be a registration link for that on our website, and I believe Esther can link that into the chat as well. So once again, thank you so much for your time here today. Enjoy the rest of your Tuesday, and feel free to let us know if you have any questions. Thank you very much.
Thank you all so much.
Thank you, guys. Thank you.
Thank you.